let's say that there's matter, right? Of course, I mean, obviously there's matter.
There is matter.
But that's Hey.
Hey, Christian. How are you doing?
That's enough small talk. What is your official title and background?
I'm an anesthesiologist. I'm an intensive care medicine doctor. And I also do ECMO.
Okay. And where'd you go to school?
I went to school in Virginia and in Wisconsin, kind of along my path.
What goes at the end of your name?
At the end of my name is D.O, or Doctor of Osteopathic Medicine.
Osteopathic used to just encompass more movement and muscular styles of healing.
Yeah.
But now they cover everything that.
I would say it had a skew towards like physical therapy like stuff, right? How the muscles and skeletal system interact with the rest of the body and health and wellness.
Let's say I suddenly have a change of life crisis and want to become a doctor.
Okay.
What does that journey look like? What do I need to do?
I guess a lot of things. You have to start with basic prerequisites in the sciences that all medical schools require that you have. After that, you have to take the MCAT, which is the medical college admissions test.
Okay.
Score well on that, apply, get into schools, go through 4 years of medical training, and then a residency, kind of where you do the functional bits of medicine.
And so right after med school, you get the MD.
Yeah.
But you don't get the license, right?
Correct. Yeah, you go through your 4 years of medical school, you graduate, and then you have a title, you get a
okay, so beware out there if you see just MD, because you can open a practice legally just as an MD, right? Without being trained in residency.
Yeah, if you've gotten your license and stuff like that, yeah, you can practice medicine without going through specific training in a field.
Okay. Well, so first you take the step one, which is midway through med school, correct?
Yeah. As you go through med school, there's multiple kind of standardized tests that you must pass. Mm-hmm. And your score on those determines your future.
I see.
Score high, you can do whatever you want. You can be a neurosurgeon, you can be an ophthalmologist, you can be a family medicine doc, whatever.
Right.
If you score low, you can only do certain specialties that are not competitive.
Right. And is this because of a high demand for certain fields, or is this because one field is perhaps more challenging cognitively? How are they judging this?
I think a lot of it is like work-life balance kind of thing. Okay. Like who makes a lot of money and doesn't have to work a lot of hours.
I see.
And so there used to be this idea of the road to success, radiology, ophthalmology, anesthesia, dermatology. Right. They all make good money, and their working hours are generally considered to be better than kind of other specialties.
And you had mentioned before that now they're moving away. Now it's a pass-fail step one.
Yeah, I just heard this the other day.
Oh, okay.
Didn't know that it had changed to that, but yeah, now it's pass-fail. That's so yeah. If you pass, you can in theory go on to any specialty you want. You're not going to be limited.
And we'll see how that plays out.
If they didn't score high enough, but they always wanted to be an ophthalmologist, and now they're forced to go into some specialty they're not really interested in or excited about, like that's probably not going to make a good physician. Okay. So you take step two, you kind of seal your fate a little bit. Then there's step three, which is at the end of med school. Is that right? Yeah. At the end or after you've graduated. At some point, take your step three, and then you're licensed. You're matched with a residency. You do that 4 years, and then to get board certified, you must go in front of the board, take the final. What is that called? Just board certification. It depends on each specialty. So yeah, you go through your residency, you graduate, and often you practice for a year or two, and then you take. Usually, it's in oral boards. During residency, you take a couple of written boards that you must pass also to progress on. And then the very end thing is an oral board for most specialties, where you sit down in front of a group of people who have years and years of experience. They fire off questions at you, throw you some scenarios, and if you answer appropriately and they deem you to be safe to practice, off you go, you're board certified. Yeah, but that wasn't enough for you.
You went for a little extra bonus, right?
Yeah. If you want, instead of going just through residency, you go through residency and then you choose at some point to do a specialty or a subspecialty to your already specialty.
Right.
So like I chose to do critical care.
What is too early to decide to go on this, 16, 17 year journey? Is there something that you really should understand before embarking?
I don't think there's anything that's necessarily too early, right? There's plenty of people that, feel like they knew that they wanted to do this since they've been 10 years old or whatever.
Yeah. Right.
In their kindergarten book, that's what they wrote. I want to be a doctor.
Right.
And there's other people that decide when they're 40 years old, that's what they want to do as their second career.
What's the latest you've seen someone finish?
That I've seen? I think in my class, we had someone that was 45 starting out.
My mom, she went to medical school in Bulgaria. Mm-hmm. And when she had to deal with terminally ill children, it took a really heavy emotional toll on her, one that made her decide that it wasn't for her. Mm. And similarly, when I was in high school, I actually really wanted to be a doctor. I was volunteering at a hospital. I was, studying biology and anatomy on my own. And, my mom saw this, but she actually convinced me out of it. And for once, I listened to her about something.
Mm-hmm. Nice.
And today I'm grateful because, she saw that I did not have the appropriate passion to study and sit and sacrifice, the different interests and activities and friendships that I had. And she knew that that would be a huge roadblock for me. Are these things to consider?
Yeah, totally. I mean, there's, I think, personality types and whatnot that lend themselves to this kind of career, and there's definitely other ones that don't.
Right.
And I think, to be interested in this and to succeed well, you have to have like a lot of specific traits, perhaps.
What would you say would be like the common traits you've noticed among your colleagues?
Well, I think at a base level, everyone has to be a masochist a little bit because it's a pain to kind of go through the whole process. But I guess specific traits realistically might be someone who just enjoys learning, someone who's very organized because you have very little time to learn a lot of information, and if you're not organized and focused, you're not going to succeed.
Take me through the grind. You get into med school.
Mm-hmm.
Was there a moment where you were met with the full scope of what you're about to begin, and was it humbling? Did you find that you possessed the traits inherently, or did you find that you had to suddenly completely change your routine and your beliefs and everything so that you could become the correct mold that would succeed in this field?
Yeah, I think for a lot of people, it's probably a bit of a slap in the face when they first start. Personally, I did a master's degree. It was relatively intensive before it. So I did,
after undergrad, you did a
master's,
in molecular and cellular biology. Okay.
Yeah. I think I had a good idea of what it took to be organized and to study and to work a lot harder than we're doing in undergrad. And so I feel like I thought I knew, even with that background, I thought I knew, like, I can handle this for sure. And then you get in and it's, despite that, it was still a bit of a slap in the face, how little free time you had, how much time you're having to put into, classes and all this stuff. And yeah, I didn't really recognize the sacrifices you'd have to make
right.
to succeed.
Okay.
And like the amount of time you'd have to put in to win.
Right. Well, what type of learning process and brain strengths and reward processes are most advantageous to go into in med school, would you say?
In med school, you just have to have like a strong interest in learning and progressing, and it has to kind of make you excited to learn something and then show you understand a thing. Like that has to be like very satisfying to you. Otherwise, you're not going to survive 4 years of that plus 5 more years of that.
Right.
So you have to be interested and excited, and it has to give you some personal satisfaction.
what did your life look like? I mean, I hang out with my friends here once in a while. I exercise, I do this. Like how much of that changed in that period?
Oh yeah, a lot. Yeah, it's painful. There's periods of time where maybe you have a greater understanding of the material. You don't have to spend as much time studying it to get good grades and stuff like that. And so you have more time to hang out with friends and family and exercise and pursue your hobbies. But still way less than you would have otherwise.
Right.
You're not going to get better at your hobbies. Yeah, and then just on a general day-to-day basis, I mean, you're much more consistent, I feel like, with what you're doing. You have classes until 4 p.m. Then you have to go home and study for the test next day, and then you have to do things, and all of a sudden it's 8 or 9 p.m. and you're like, oh gosh, I need to go to bed because I've got to repeat that over and over again.
Right.
And so it just your days are generally like very consumed.
Right.
And
when you also develop this sense of urgency, let's say you have just 1 hour, right? You have to make it count.
You're always nervous about the next thing. Yeah. And if you kind of waste a couple hours here or there, kind of watching TV or trying to, having a book in front of you, but not actually studying it because you're kind of like pseudo studying, you have to be efficient.
Right.
And you have to do things with intention.
How do you know who is kind of ready to be pushed into the anesthesiology sector?
In anesthesia, I feel like it's someone that has like a lot of focus, a lot of vigilance. They're a planner, an anticipator specifically.
Right.
And then they have to be generally fairly affable, they have to be able to be humble because you're gonna be working with all sorts of different specialties all the time. You're never gonna be the one who knows, more than that specialist does.
Right. Because you have to be present at every type of surgery, every type of procedure that requires any kind of anesthesia, and it's impossible to fully understand each one.
Yeah.
Okay.
And part of our specialty is also kind of being consultant, right?
Right.
And the surgeons have to want to work with you, and so you have to have pretty good interpersonal skills and ability to communicate and stuff like that. And if you don't have those, people aren't generally going to want to hire you. They're not going to want to work with you. You might not last long in a private practice group.
Let me be a sidekick in your brain for a day, man. Take me through what it looks like when you wake up the morning that you're scheduled for a shift, and like give me the nitty gritty. What are you doing when you open those doors? When you're wheeling the patient out? When you got the machines going? What's going on?
Yeah, well, let's say I'm not working with residents or nurse anesthetists. I'm doing just like a case by myself. Throw your scrubs on in the locker room. Come upstairs. Go to your OR. Make sure your equipment's all functioning appropriately. Maybe drop your drugs and stuff like that. You head out to the PACU or the pre-op area. Usually you get there and the patient's already in a gown. The nurses have put in an IV, and they're kind of just sitting there nervously, anticipating what's about to happen. And it's generally the first time you're meeting them.
Right.
And so you walk in, you have to introduce yourself, and hopefully they can gain some confidence and be a little bit more at ease, like meeting the person who's gonna be like taking care of all their vital functions,
right,
while the surgeon is focusing on the operation. Take a medical history, kind of ask them some very specific questions, see if they have any specific concerns.
And how specific is each person's medical history to what you're about to, as far as dosage? I mean, are there big ranges as far as differentiating what you're going to be dosing out?
Totally.
Or is it extremely specific? Like, I'm 33 years old as opposed to 32. I am, 5'9" as opposed to 5'8". Does that matter as much? Or are you looking at like wider ranges of like, oh, do you have high blood pressure and this kind of thing? Like,
no, yeah, totally. All that stuff matters. In anesthesia, like a very common term would just be like titration.
What is that?
You give a little bit and you see how they respond.
Oh,
give a little bit more, see how they respond. So you can totally just titrate to your effect that you want. So
you're actively, you have to be flexible. You cannot be, well, I did this last time like this. And
it depends on how tenuous someone is. If someone is like very tenuous and you're worried about them, dying the moment you push a bunch of drugs into them, you're probably not going to want to just, ballpark it and give a whop of stuff.
Right.
Right away. You might want to go slower with that if you have the luxury of doing that.
Okay.
But yeah, all those factors definitely play in. So an 88-year-old guy who's got a bazillion medical problems. He's acutely anemic and stuff like that, and you give a medication to put him to sleep. You might need a tenth of what you or I would get.
Right. And what are the different machines you're working with?
Generally, it's in the OR we have an anesthesia machine.
Okay.
And that is delivering oxygen. It's monitoring CO2. Usually there's a vitals, heart rate, blood pressure, all that is connected to it, and a gas delivery system.
Okay. And then you mentioned also something, a Belmont.
Yeah, that's another machine. Yeah. So there's different like blood delivery machines.
Okay.
So if someone's like bleeding a bunch, you need to give blood back quickly. You can't just be sitting there squeezing a bag of blood. You have like 10 other things you need to be doing in that scenario.
Right.
And so it's a machine basically you just dump tons of blood into and hit the button to go up.
Okay.
Give more, give it faster, or they got enough in, go slower.
Well, take me through a scenario that you've experienced.
Okay. Yeah. I mean, like I guess
a case, I should say.
A whole case all the way through
let's
kind
do
of thing. Okay. Yeah. So saw the patient in pre-op, take them back to the operating room, connect them to all your monitors, ensure that they're working appropriately, put them a face mask over them, give them oxygen, and then you induce them for general anesthesia. You push all the drugs in. They are asleep. Maybe you relax their muscles. You put a breathing device in, take over that breathing function, make sure their blood pressure doesn't drop or go too high, that sort of thing. And then you start getting access, is usually what happens next. So let's say this case is someone has an aneurysmal aorta. So it's a dilated aorta, and they're going to need to open their belly, open that aorta up, cut that section out essentially and put a graft in instead.
Yeah.
So you can anticipate that there's going to be a lot of bleeding potentially in that case, or the potential, right? Because you're operating on the aorta.
Right.
So you need to be able to respond if there's a ton of bleeding, for example, or if they need medications to bring their blood pressure up or down kind of acutely. So you need access. So access is peripheral IVs sometimes. And so you need to go over the side of the bed and put a bunch of IVs in. Access could be more intensive monitoring. So an IV that goes into the artery to measure the blood pressure every heartbeat, rather than when a cuff goes off every few minutes. And then access could also be a very big IV in the neck, for example, to run a Belmont through, right? It has to be big, it has to be fat, it has to go through a central vein because you need to push a ton of volume through that over a very short amount of time. So that'd be another piece.
So you need to be an absolute expert at setting IVs and finding, just the mechanics, the physical mechanics of doing that. You cannot get there and fumble it and take a long time, right?
You totally can fumble it.
Oh, okay.
Sometimes you do. Sometimes early in your career, maybe you fumble it more. But yeah, the goal of the training, one of the goals is to get you to a spot where you can do the have a 99% success rate on your first IV attempt.
Right.
That way the operating room moves efficiently, right? Because the surgeon can't operate until you're done doing your part.
Right.
And so, yeah, you want to have a very high first pass success rate on all your things. And, all your things should have a low complication rate. They all have complications associated with them, but you should be able to do them kind of fast, smooth, and without any of those complications.
Okay. So let's say that case you just mentioned, you did everything fast, smooth. The person is knocked out. What are you doing during the surgery?
So parts of it, you're just documenting, right? You got all these things in, you're ready to go. And now the surgeon has to, prep the body, kind of expose the area they're going to operate on. Maybe you have to flip them upside down on the operating room table because they're going to go in through the back, stuff like that. So you're kind of helping do that. And then there's a period of time often we kind of are just documenting and monitoring the vital signs,
right?
Intervening if you have to. So there's a period of time of that, and then things might get a little more critical in the case, right? They've made their incision, they've dissected down to the aorta, and now they're going to clamp the aorta, for example. Okay, you clamp the aorta in a certain spot, your blood pressure might skyrocket up.
Right.
Not great for you.
And so let's say the blood pressure is going up. What do you do immediately?
Well, you decide on how concerned you are about that blood pressure going up, how high it might go up to. That would incorporate some of their comorbidities. So, for example, if they had a intracranial aneurysm that was known about, like you don't want to put that under a bunch of pressure, and so you might be very aggressive about lowering that. Or if they're a healthy young person, you might tolerate a higher blood pressure and not be too concerned about it.
Okay. And so to lower it, you just simply increase the dosage of something. Okay.
Give one of whatever choice drug you want to give. And there's many. If you want to bring the blood pressure up, one of many different choices. You can start an infusion of whichever thing you chose, or you can just give a single dose of it, depending on how long you think this alteration in their hemodynamics will occur.
How do you bring them back?
That's relatively simple. You obviously monitor how much they're getting during the case. You make sure they didn't get too much, so that they have a prolonged wake up at the end. So if you kind of did all your things right, basically what you end up doing at the end is turning off the inhaled gas that keeps them asleep, and they just kind of breathing on their own, and they just exhale all the gas, and they just exhale themselves to wakefulness. And okay, cool.
Does anybody in the room get affected by the gas that's been breathed out or comes through the pores?
No, it's all scavenged generally through the machine, and we have like a scavenging system, so it's not released into the operating room. It's not good if it gets released in the operating room. And then I guess at the end of that, right, once they like are just barely starting to wake up, you're talking to them, making sure they know what's going on, they're calm and not freaking out, and then you take the breathing tube out, take off monitors, go to recovery room,
on to the next one,
and you move on to the next one.
Wow. Okay, how common are certain complications? Like, for example, let's say you're going to a procedure and you Wikipedia anesthesia and whatever, and you're nervous about it. You'll see two things that can happen: pulmonary embolisms and malignant hyperthermia. What are those, and how common are they?
Well, I'll say in general, anesthesia is itself is very safe. It used to be much more dangerous, but now we have better monitoring systems, better drugs, et cetera. So the actual anesthetic delivery is generally quite safe. But things that can, everything that can happen to the body at any other point in its life can also happen to you while you're under anesthesia. It'll just present differently. A pulmonary embolism can definitely happen. So a pulmonary embolism is basically a big blood clot, often formed in the legs, that breaks free and moves up and gets lodged in the pulmonary artery. And that can be entirely unnoticed, and no symptoms. The body doesn't really recognize it, and maybe if you get a very detailed scan, you'll see it. Or it can be massive, and it can cause immediate death.
Wow. And hyperthermia, that's when your body temperature goes up, but this is a genetic mutation.
Malignant hyperthermia is a kind of a specific genetic mutation that no one would know about unless anesthesia existed.
Really?
Right? Because it's only something that happens when the body responds to certain drugs that you give them. And basically what it is the drugs interact with a receptor. The receptor inappropriately releases a bunch of ions or charged particles. They transfer through a membrane, and it causes your muscles to contract. And they just contract uncontrollably for a long period of time. And you can imagine that has like a lot of disastrous consequences. Your muscle cells die, your temperature skyrockets, you develop acidosis and all these things. Potassium gets released. Potassium in the body can, has a very narrow therapeutic range, and so it can stop your heart. So it's a very serious thing. That you have to intervene on immediately. And
you would just use different sedatives and
So if you knew someone had it, you would avoid giving those drugs, and if someone develops it, you would stop giving those drugs and give some different ones to treat it. And if you knew someone had it, personally, I would remove the drugs that could potentially cause it, even from the operating room. They're standardly attached to our machine. But just to make sure, if someone comes in and gives you a break or something like that, they don't inadvertently turn it on, disconnect them, push them outside of the room, make it so it's not even feasible for it to happen.
So anesthesia at its core it's essentially trying to induce amnesia, analgesia, and muscle relaxation. Is that right?
Yeah.
And sedation.
Yeah.
And can you tell me a little bit about each of those and the drugs used and what exactly is happening to your body so that it can no longer form memories of the surgery or feel the knife going into your flesh?
Yeah. So for sedation and hypnosis and memory formation, a lot of those drugs are very similar drugs. So they kind of hit both the memory formation and sedating someone kind of go hand in hand.
Okay.
Like a way to conceptualize that might be for an average person might be thinking of being blackout drunk in college. Right. It's a very similar receptor that does these things, and right, you drink too much in college, it hits this receptor really hard, and you don't form memories, and maybe you're unconscious, on your neighbor's front yard.
And so you're targeting that same receptor.
Yeah, a lot of them target same receptor in kind of different ways. And so some of them you give, and one we often give to relax someone, take away their anxiety beforehand. Also works as an amnestic. And so they don't form memories. So they might still be interacting with you, talking, seeming relatively normal, but calm.
Yeah.
But they have no recollection of that conversation, 4 hours later after their surgery's over.
Oh, wow.
So that would be one type of drug. Other ones like pain medications, for example, that just block the body's sense of pain. And so that could be like a morphine-like drug that kind of like you still sense pain, but it's dulled and more tolerable. Or it could be a drug that completely blocks the nerve impulse, and so your body doesn't even feel the pain.
Right.
It never gets to your spinal cord. It never happens.
Never gets communicated.
Yeah.
Well, and so how does the drug block that sensation? And what is that sensation exactly? What is pain, Travis?
Gosh, I don't, philosophically, I don't know exactly. Like why does the body like have a pain sense? I think there's an evolutionary basis to pain. Like you have to have pain to survive, to avoid trauma and stuff like that. Why does it have to be interpreted like so severely or chronically? I don't know. Like why couldn't it just be like an irritating tickle?
Sure.
It'd be much more pleasant to live life.
Well, and what is the mechanic of it? When you prick your something, what is happening? Exactly?
Specific receptors kind of in your body, on the outside of your body. So they get activated. They send a chemical, electrical signal that travels through nerves up to your spinal cord up to your brain, and then your brain interprets it as pain. As does your body, right? Even if it hits the spinal cord, there's often a kind of a bounce back reflex that says like, ouch, and you withdraw your hand from the flame before your brain even registers the pain.
I see.
Okay.
And you were saying, in our discussion prior to this, that it's not 100% important to know the exact chemical processes of the chemicals you're working, the exact neural pathways. I feel like
totally.
A lot of times when people go into medicine, they look at biology and they say, wow, I guess I need to know every single aspect of every cell and what it does, and what, and they feel intimidated by that.
Yeah. And that's what like undergrad and like high school biology, right? It's all very cellular, all very nitty gritty. But yeah, in the end, to be a doctor, you're kind of a country bumpkin of understanding, in my mind. The nuts. All you need to know is the nuts and bolts, and like, does this drug cause this thing? An average doctor doesn't need to know most of that nitty gritty stuff. Maybe it helps you to learn on your way, but I'm sure plenty of people can go through in other countries can go through a medical degree, become a great physician at the end of it, but they don't have to have like this in-depth understanding of exactly how that receptor works, like what ion channels are involved, unless you're doing research or getting a PhD,
right? That
kind of stuff.
Okay, so you can leave some space in your brain for the other things that a doctor needs, such as coordination, stamina, personal skills.
Totally. Yeah.
Really a doctor has to wear many hats. They can't just be a molecular genius. They have all of these. What are the hats? I mean, what are all the hats that a doctor needs, really?
Yeah. Well, first I would say a little fun example of kind of what we were talking about before. Is often you'll get like a medical student that'll ask you like a question, and their questions are almost always very molecularly heavy. Like, what is the mechanism? How exactly does this occur?
Yeah.
And if you're a decade out from medical school, you'll like think back, and occasionally you'll be able to like pull something out.
Yeah.
But like see this happen like all the time, and most of the time people are like, gosh, I don't know. Like, the medical student is probably the one who's closest to being able to answer those questions.
Wow.
Or maybe the first year resident,
Right.
But the attending who's been working 20 years probably doesn't know.
Right. Instead, they have this lexicon of experience of patients and what they need and what the procedure is, and it's replaced with that knowledge. That is
much more functional knowledge.
I see.
Yeah.
Okay.
Other skills like you're asking about. There's definitely interpersonal skills, like how to interact with families and patients and surgeons and other medical staff. And then there's definitely a procedural component.
Right.
If you're doing a procedural specialty, maybe you're doing a very non-procedural specialty and you just need to be able to think, or maybe you're doing something like anesthesia, where there are a bunch of minor procedures that you perform that are you have to do in a detailed way. And so you need some hand-eye coordination and stuff like that for sure.
Can you talk to me about the nightmare scenario where if it happens, if you've seen it, where you hear these crazy stories about people that have become paralyzed yet are still able to feel pain and sensation, but they cannot communicate that on the table?
Yeah, so I would say that nightmare scenario is incredibly rare.
Okay.
I would say incredibly rare in
but
general.
Have you come across it?
I was gonna say no initially, but I think I have seen it occur once. Yeah, which I think is again, it's incredibly rare.
Okay.
And the severity of it, probably depends on what they're experiencing.
Okay.
So if they're getting their belly opened and they're totally aware, like oh my God, horrifying.
Sure.
If they're getting a colonoscopy, something that you could do in theory awake, probably not super traumatizing.
Okay.
So it totally depends, and I think to me the interesting thing about like awareness or this nightmare scenario, everyone like very much fears it.
Right.
I think it's way more commonly reported. But it's kind of really hard to interpret, like, did someone like truly experience that?
Right.
And maybe you can definitely identify it by being like, oh shoot, you made a gross medical error and didn't give the drug that made them asleep.
Sure.
Like that could be pretty clear. Or maybe your machine malfunctioned and it didn't deliver a drug that you thought it was delivering.
Right.
Pretty clear.
Sure.
But I think a lot of times it's like a patient reports they were aware, and so did that you're giving them all this medication and stuff, like did they have a dream while they're waking up from anesthesia or going under anesthesia, and they're interpreting that as something. We wake people up in the OR at the end of surgery, and they're very fuzzy and groggy. Do they remember hearing the beeps, people talking, people touching their body, and they're like, oh, I was totally awake under anesthesia, when in reality, like, we were waking them up. And they just remember these little tidbits because they're not totally forming normal memories yet.
Right.
It's kind of hard to parse out exactly what was like a severe, horrible traumatic experience, and what was,
Sure.
Someone was very nervous about that experience, and therefore they're very sensitive to anything that could have possibly been it.
It's said that about 20% of people report dreaming during surgery, but really it could just be in the time that they're waking up, and then just remembering that and stretching that memory over a longer period of time than actual.
Totally. Yeah. I mean, if you look at someone's like brain waves while they're under general anesthesia, like they're not dreaming.
Okay.
There's nothing, there could be absolutely nothing happening there.
Interesting.
And those people wouldn't dream.
Okay.
And what people, might report as, dreaming also might depend on how, under anesthesia they were. Maybe you're just doing like a moderate sedation,
Right.
If they're asleep, you can kind of manipulate them. And if you poked them really hard, they could kind of wake up and open their eyes and mumble something.
Right.
Those people probably for sure dream or, have some things happen to them, in their heads. But generally under general anesthesia, I'd be fairly surprised if, those clearly occurred during like a deep general anesthetic.
What would you say to people that interpret our human existence as something that we inhabit a body, and therefore when the body is brain dead, perhaps a soul or something like this is experiencing a dream and then comes back into the body?
Gosh, I don't know how I'd explain that.
But you
as a non-spiritual person, that would be hard to conceptualize for me.
All right, but based on your personal history and your experiences, you would say the body is it. The brain and the body is consciousness.
Yeah, connected, conscious.
I've lived with a doctor now for 4 years, and have made many friends in the medical industry, including you. And I've noticed that you possess this extra gear, this overdrive, where when you're taking care of a patient, you can completely ignore any bodily needs, any family or relationship drama, any kind of moods or tiredness, and you are just 100% zoned in the moment, and for not just an hour, for maybe sometimes even a 16-hour shift or something like that. And I have to ask, what is the come down from that? Is it something that you just have, or did you have to learn it?
Yeah, I mean, that kind of overdrive, that you're mentioning, I feel like that is, I certainly feel fatigued and, tired and, distracted, potentially during that time. But yeah, there is totally moments when you are ignoring bodily functions, ignoring emotions, and you're just, you have to do the work because it's coming at you fast, and the speed of which you do the work matters.
Right.
So yeah, there's definitely periods where you are like, holy shit, like I haven't, gone to the bathroom in my entire shift yet. Right. And my shift ended 2 hours ago, but I'm still here because there's stuff happening.
Right.
And those moments definitely happen. And yeah, it can be like insanely busy, and maybe you're, working 9 days in a row, which I just finished yesterday.
Yeah.
And then all of a sudden you're totally preoccupied for, 9 days in a row. And then, like today I'm released back into the world. And it's like it's a total struggle.
You have to re-download your personality. Like,
exactly. Yeah.
I mean,
like, what do I do with myself now? Like, what did I used to do for fun? Like, do I still enjoy that? Like, okay, I like climbing outside. Like, is the weather still good? Like, do we transition to winter? Like, where do we stand on everything? Like,
yeah, I mean, doctors are incredible people. I mean, and one image that I have in my head is, I was at this gas station, which is by my house, which is by one of the hospitals here, St. Vincent. And I see this guy wearing his scrubs, and it's windy and cold, and he's just downing these Reese's Pieces real quick, and you can tell it's all he has time for. And one thing I have to say is that I find that doctors in general seem to take care of their own health dead last.
Totally. I generally would agree with that. Yeah. I think that the new age of doctors, they're graduating now and graduated in the last decade, are better about that and focus a little bit more on work-life balance. But there's, plenty of specialties where, I think people feel like they can't do that and they need to be working 24/7. And they totally neglect their own personal health and mental health.
And how have you found? Things. I mean, how have you mitigated that?
Yeah. How have I not become a martyr to my specialty?
Yes.
Yeah.
What have you done?
Well, I think at some point in the past, I kind of realized that work-life balance, was super important, and it could like totally change your life if you are on the wrong side of that. And I think from some of those experiences, just kind of recognize that like that's not where I want my life to be. Like I get some happiness from like having fun interactions, interesting cases at work, and I get a bunch of happiness from having friends, having free time, pursuing hobbies and stuff like that. And so I think it's just like my past experiences have taught me that like, oh my gosh, you should not work full time if you can avoid it. Like, and full time for a doctor is totally different than like, a 40-hour week, average week,
Right. Full time is 80 hours, right?
Yeah, potentially. Yeah. Certainly as a resident, it can be. And, depending on what your specialty is, it can definitely be a lot of hours.
Right. And in residency, there really was no time for family, and especially if you have to move away for residency, right? I mean,
yeah.
What were you able to squeak in?
Yeah, if you move away for residency and you're far away from family, I mean, you can only visit them, on holidays where school is off and stuff like that. And so, yeah, I mean, if your friends are all back where you're in your hometown and they decide to have a wedding on a weekend in September, and you've got 4 exams, coming up, like, okay, you're gonna miss that wedding.
Right.
Probably. Or you can try and squeak it in somehow, maybe study a bunch like the 2 weeks ahead of that. And,
right.
Try and make it so that, okay, I'm gonna take a day off to drive up there, a day for the wedding, a day to drive back. Like, you have to plan all these things like way in advance, but chances are you're definitely gonna miss things in life.
And as someone, you've been a rock climber, right, your whole life, pretty much, growing up in Wisconsin.
Yeah, 22 years.
And developing different boulders and routes there. And,
yeah.
and you had a dream, in fact, at one point to climb El Capitan and Half Dome in a 24-hour period, correct? And,
yeah.
And, climbing is this thing where it's this constant progression in battle of training the body and mind. And can you tell me what it was like to have to put some of that on hold, and how far did it set you back?
Yeah. I mean, it's a total setback. At best, you can maintain, I would say, an average person. That the important thing in climbing is consistency, right? Like very regular exercise and training for like whatever your goal is.
Right.
And I think going through like a medical profession, like you entirely lack consistency in life, right? You might be doing night shifts, might be doing day shifts, you might be doing 8 days in a row, you might be doing 2 days in a row. You can just have zero consistency in your schedule. Right. And so kind of having that goal of climbing both the nose and Half Dome in a day, routes that might averagely take 2 days and 4 days to climb. About the only time you can get consistency is 4th year.
Okay.
You've
of med school or residency?
Of med school. You've applied to your residency. Yeah. The application is in. You've done all your interviews. Yeah. So anything that happens, and that's usually like in January-ish.
Yeah.
So everything after that is kind of inconsequential, right? You don't, your preceptors might just send you home early every day. Your grades there don't, matter. That no one's going to write you a bad review that a residency is going to see. And so you can spend a lot more time on your, other goals in life. Mm-hmm. And a lot of people do that. A lot of people vacation and stuff like that. So my goal in my 4th year was to climb those 2 things before starting residency.
Yes.
And I had.
Can tell us what happened.
Yeah, my training regimen was, to be able to run, essentially marathon shape.
Yes.
And so I'd, run, maybe 6 to 15 miles a day.
Wow.
Just, depending on, what the weather was and stuff like that. Sometimes I'd, run to the climbing gym and then climb on their cracks, just up, down on an auto belay for, 2 hours or something like that. Yeah. Run back home. And then my backyard, I had a really, really tall tree that I had fixed a rope in. Mm-hmm. And so I grabbed my Jumars and I would just, try and put in 1,000 feet of Jumar.
Wow.
Because, you need to have it's a third kind of skill you need to have
to do those.
And so, me and 2 friends were kind of all doing that training at the same time in different places in the country, with a plan to go there and accomplish that goal.
Yes.
And then we never even attempted it.
You were ready to, though. You were about to.
Oh, totally. Yeah.
And
I feel like I was in insane shape. And so I had, me and two friends that were going to try and do this together. And we ended up like entirely not doing it. Because we had a very set amount of time that we had.
Yeah.
And, I think one guy was finishing his PhD in education. And I forget exactly what it was. I think maybe didn't quite do his dissertation in time and needed another month, so he couldn't do it.
Okay.
I think another person was going to have a baby, and so the timing of the baby kind of interfered with our week, and so like it ended up being just me having enough time off to go do some climbing, but we never got to attempt that.
And that was pretty much the fall before entering residency. Is that right?
That was the spring, so it was like
Spring.
June before residency. So I mean, we had gotten to do Half Dome and the Nose in a Day and stuff like that like years before.
Yeah.
But never got to make the big attempt.
And so entering residency, you knew you would have to wait, and
Those dreams were put on hold.
Yeah. And
Yeah.
So you spent 4 years of residency. How often would you get to climb it, if at all?
That would depend on like the rotation. If you're doing your cardiac surgery rotation, you have to be in super early. The cases are pretty intense. You need to be well rested. Yeah. And other times maybe you're doing like a pre-op clinic. You show up at 10 a.m. and the day ends at 3, and it's generally just a nice relaxed rotation.
I will work as hard as I can to make sure you get that goal, man. I think now that you're established, you're in anesthesia and everything, and you have time to train.
I'll consider keeping you as a climbing partner. No, I will keep you as a climbing partner.
Oh, really? I made the cut. Okay. Well, one thing I wanted to ask, so not only are there sacrifices that are personal, to be a doctor, you have to have these coping mechanisms, that are. You take me through, because you are an ICU doc, right? So
Mm-hmm.
So you see incredibly intense situations where, what is the percentage of survival sometimes?
I mean, that totally depends on what they're in for. If they're in for like a standard coronary bypass graft surgery, they come to the ICU afterwards.
Yeah.
Very high. Very rarely do you see one of those folks die.
Right.
If they come into the ICU because they've been doing methamphetamines for the last 4 years and their heart has failed to the point of non-survival, like
Right.
maybe those people, most of those people don't make it out of the ICU.
Right. Take me through what it's like to have to tell someone's family that their child or their spouse is gone.
I mean, that's definitely not fun. I feel like it seems like it just seems like a lot of times it happens over the phone,
Right.
because it's in the middle of the night, or it happened while they're on vacation, or maybe they have been sick, but they went home to go do whatever their life needed to work their job or whatever, and then they kind of unexpectedly die. And so it's often it seems like a phone call, and so you call them up and tell them that, like, hey, I'm sorry, I have bad news to give you. And
You say bad news. You say,
often something like that.
say I have bad news.
Yeah.
Just to give them like a little bit of, okay, take a breath.
Kind of
or
moment
sit
to kind
down.
of be like, oh, something is going to be said that I need to process.
Okay.
And then I mean, I feel like I usually give like a short explanation of what happened, like a very short one, and like I'm sorry, but they died.
Yeah.
There was nothing we could do to get them back, and they tried their hardest. We tried our hardest, and this is where.
And what is someone's what do people say after that usually?
I find that most people seem to be, if it was, if the person had been sick, they tend to be pretty accepting of it. To like, oh, like they're obviously sad and they're upset, but it's a brief exchange, and they're like, okay, well, okay, I'm going to come in then. And I'll come in and see the body or whatever. I feel like that kind of changes a lot, whether it's like someone who's super old, 95, and their 95-year-old husband, you call him up and be like, oh, hey, she died.
Yeah.
And he'll be like, oh, well, good. Like we've been expecting this for the last 20 years,
Right.
okay, thanks. Like, and you're like, oh, you gonna come in? Oh, no, that's okay.
Right.
You know, you can have interactions like that, or if you're trying to, tell someone that their, 18-year-old child died, it's going to be a totally different interaction and a totally different like emotional experience that they're going to have.
Yeah.
And, you're going to react, just, as a human to like seeing that emotion in them. You're going to, feel that yourself too.
Right. And is it important to show a sense of feeling? What are you trying to communicate essentially in that moment as far as how you feel about the situation?
Yeah, I mean, I feel like for the most part, I think you're trying to communicate just clarity.
Okay.
If it's over the phone or somewhere else, like you want to kind of lay down the raw facts as they are, to make it very clear that they're dying or just have died or whatever. And then, yeah, I mean, I think it's probably comforting to the family, if they see that you're upset by this too. Right. They know you tried hard. Right. Because, it depends on someone's background, but some people have a strong distrust of medicine.
Sure.
And if you come in and coldly say they're dead and, is there anything else you want to ask me? No? Okay, bye. Like, they're probably not going to feel great about it. They're not going to think everything was done. Right. Yeah, if you show that emotion, I think, I assume they, someone appreciates that.
Right.
And they feel like everything was tried. And
I don't know if I could do it, man.
It's not fun.
It's, I mean, and there's, that's not even the hardest situation. Let me ask you about maybe the most difficult situation, which is when, we all have bad days on the job. Mm-hmm. We all make mistakes. We're human, but in the medical field, when someone perpetrates an error, that could have lasting consequences. That it could mean death. Yeah. How have you seen your colleagues deal with, making an error? Have you ever made an error that has led to something like this? And how do you move on from it?
I think that's super challenging. Obviously, I think that's probably way more complex and difficult than just delivering a bad news to a family member. So I think there's like an intellectual processing that occurs, right? People kind of review what was done, what happened, could they have seen this coming, like what procedurally could they have done different. So there's like this intellectual processing, and I think a lot of people probably stop there, right? Because I feel like we're not great at the emotional processing part of it. We're not taught that. It's not really trained. It's something that has to be kind of like lived and learned.
Really?
And so, I think some people are better than others. A lot of what happens is there's often like an immediate kind of decompression. Mm-hmm. Right away, people talk about, their feelings, like, maybe it's an hour after the thing happened, maybe it's the day after, but everyone kind of gets together who's involved and they talk about it. Mm-hmm. And then I think after that, it's kind of all up to you for the most part. Do you talk to like a, grief counselor? Do you talk to your psychiatrist about this? Probably talk to your family and friends about, what you're feeling. Right. And so, hopefully people are doing that and like processing what happened. So intellectually, thinking about it, seeing how they can prevent it, because that's what you need to do to learn and grow. Mm-hmm. And then also hopefully taking care of themselves and actually processing those, awful feelings.
Right.
I think, it's probably pretty common that most people have experienced something like that. Mm-hmm. I think you might colloquially hear it called a clean kill, right? Like something where you very clearly and obviously cause mortality in this person.
It's not that the person was about to die, it's that things were going okay, but then just something happened by accident.
Yeah. Some mistake was made, you made that mistake, and it very clearly led to immediate death.
Right.
Or, death, quickly. And I think those are uncommon, but, most people will probably experience something like that in their career.
Yeah.
Especially if you're doing, surgery or, ECMO, or something that's like very invasive, like that's going to happen.
ECMO is where you're literally running the person's heart and lungs.
Yeah.
through a machine as opposed to their
bypassing their heart and lungs. You know, for COVID, for example, you know, your lungs are shot. Conventional ventilation isn't enough, and you have to essentially bypass their lungs, do the job of the lungs. But it's, you know, very invasive to do that.
Right.
So yeah, I think I personally, I can't think of a time where I've had like a, you know, what people call a clean kill, where it's very clearly been me, but I am certain that all of us have kind of contributed to something like that, you know, whether it's, you know, something kind of more nebulous, like I decided to stop antibiotics on this person because I didn't think, you know, they had an infection. And 3 days later, all of a sudden, you know, now they're in, you know, septic shock.
Wow.
Some infection is occurring in their bloodstream.
Right.
And, you know, the family sees that, and that's the last straw for them. And they're like, okay, they got sicker again. Like, we're going to stop. And they, you know, withdraw. You know, maybe if you hadn't stopped those antibiotics, this wouldn't have occurred, and they wouldn't have withdrawn, and they would have made it back out of the hospital. Right. And so you don't really know for sure if that was your fault or not your fault. And so I'm sure like that kind of scenario happens a lot more than this very obvious one. And those, you know, it's hard to attribute to yourself like clearly and definitely. So not as much processing and thought has to go into it, but there's a lot of like the educational component that goes into it. Right. Trying to learn from that as a group or a team. You know, versus, you know, you having to take on all that burden yourself.
And recognizing you're fallible, you know, and the humbling aspect of that. And would you say that part of the thought process is committing yourself to say, well, I could either stop practicing medicine where then I won't help anybody else ever again, or I continue and continue to save lives and continue to improve, you know?
I mean,
there's always those two options, right? And well, there is also a third option. Unfortunately, you know, it looks like the top profession, the suicide rate, the highest suicide rate of all the professions is in medicine. Is that correct?
I believe it's definitely near or at the top.
Near at the top, and
depending on what source you look at.
Yeah, and you know, I can tell you, you know, from having lived with a doctor, two gripes that I hear constantly are, one, work-life balance, like we mentioned, crazy hours, overnights, a lot of overtime, not being able to plan things, not enough time off. Second gripe is understaffing and shortages of instruments and you know, which obviously contribute to the extra work hours.
Yeah.
And I'm curious, you know, I want to ask, you know, you see these symptoms, is there a single cause? And if you had the ability to reorganize the system, how would you organize it as far as pay scale, as far as hours and that kind of thing?
Yeah, I mean, I think, you know, we have a average 40-hour work week, you know, in most countries for a reason. That, you know, seems like a reasonable amount to work and still maintain a life and be able to, you know, process, you know, what's going on around you.
Right.
And a lot of docs work way more hours than that. And so they don't have the ability to process their emotions. They're kind of constantly feeling like they're under stress and a time crunch. And, you know, and then on top of all that, maybe they have, you know, people dying around them, you know, so like kind of all those things I think just add up to a perfect storm.
Right.
And I think kind of on top of all that, there's the expectation of perfection. Right. Like you mentioned, that we're all fallible, right? And that's totally true. But the expectation is that you're perfect in a lot of things, right? And you never cause a problem. And so I think having that expectation and never truly being able to achieve it is a challenge.
And it's tricky because you may approach mastery, but it seems like the attendees or whoever they're approaching mastery have completely taken down any kind of personal existence. And so though they may be prone to fewer mistakes, maybe even closer to madness, because they haven't made time for anything else. So it's this terrible trade-off,
Yeah.
you know. And I'm curious, do you think medical professionals would be willing to sacrifice compensation, a percentage of the compensation in exchange for better work-life balance and more staffing and more equipment? Or is that even necessary?
No, well, 100%. Yeah. I mean, I think many people want that.
They would exchange that.
For sure. Personally, like as soon as I am able to do that, as far as getting loans forgiven and all these kind of things, like I'm absolutely going to go down to a more manageable and reasonable amount of hours. I'm not going to be working 9 days in a row. Like I'm going to have control of my life again. It's going to be great.
It's gonna be beautiful. And we're gonna be climbing.
yeah. We're gonna finally do the nose and LCAP in a day, and it's gonna be awesome.
It's gonna be great.
But yeah, so I think to reorganize, I mean, I think there has to be a different expectation of how many hours you should be working, how many hours you should be training. Remove that expectation of absolute perfection.
Right.
Things like that. Yeah.
Well, and is corporate greed a factor? Do you feel that there's these for-profit models, and I know that you work for a certain place that is nonprofit. Is nonprofit sustainable?
I think they all need to make a profit.
Okay.
Right. So there's that. Everyone needs to keep their bottom line up, and so I think yes, there probably is a portion of it that is corporate greed or just general expenses of our medical system, which is exorbitantly expensive. And I think all this contributes into burnout and stuff like that, because you want to feel valued, right? And like the times I've worked jobs where I've gotten paid like a much better salary than I averagely get paid, right? I feel like that hospital system like really values my presence, like, and therefore I feel like much more happy about being there, not just because of a bottom dollar, but just because like they are demonstrating that they feel like I'm valuable, versus maybe them giving me a pin at the end of a year saying we value you, right. Like great, but like how about you show me in a more valuable way to me,
Sure.
And so I think I think just something like that. I'm not sure if that's corporate greed or what that is. But
the way that you said you felt valued, it wasn't just the higher compensation. What were the other things that they were?
That makes me feel valued
in a hospital system. Yeah.
I mean, I think it's when someone respects your time. For example, if you're like a part-time researcher, part-time clinician, do they continuously interrupt your research time to make you do something that makes the hospital money? Do they ask you to stay extra or work extra days? Do they schedule you on your days off, stuff like that? Or is there an expectation that if someone is sick that someone has to fill in and work extra to keep the operating room running?
Right.
Or is there pressure to have like very short turnover times in the operating room, right? Because like the operating room is making money when the operation is happening.
Sure.
So when it ends and you remove a patient and then you bring a new patient back, like if that period of time is an hour and you do 10 cases in that day, right? That's a ton of time where that the room is not making money,
right? But
it's paying an OR nurse, it's paying a scrub tech, it's paying everyone a wage. And so if there's a ton of pressure to do that, right? I mean, like that's like we're talking about, it adds stress and pressure to your day-to-day life.
Well, and that's in the American medical system, there seems to be this push and pull between the Hippocratic Oath, do no harm, and the corporations that run health insurance, that run the the buying and selling of medical machines, and of course that run the hospitals, that pay the doctors and all the staff. And can you comment on that?
Yeah, I mean, I think I can see what you're saying. There's definitely like a push and pull there, and I think you can potentially see that fairly easily in many aspects of medicine, right? If a family medicine doc, needs to see, one patient every 15 minutes through the whole course of the day to pay their wage, they're trying to do their job in this very small amount of time where perhaps they are more likely to do harm because they're not spending as much time as they individually need to spend thinking about that problem. And so I could totally see a scenario where like we're getting pressured to be more efficient, be faster, do your job in the least amount of time, do that operation as quickly as you can, like those kind of things. And that, pushing people into moving too fast, not being careful enough in their operation, not having enough time to review all their medical records in depth that you need to for your 15-minute visit, whatever it is. Right. And that leading to a bad outcome of doing no harm, and maybe you do harm because you felt the pressure to move fast, you actualized that pressure of moving fast, and you moved fast, but it was not efficient fast, it was too fast. Your hand slipped, something like something happened, and there's your error, now you've caused harm. So.
Right. Well, and it's tricky because from the hospital administrator's perspective, they say, hey, we're not going to have a hospital unless we make money.
Yeah, I think it's the whole system is not working very well, and it's not necessarily always working in favor of the patient.
Right.
Everyone's trying to be, obviously, to be patient-centered.
Right.
But I think the American medical system does not really engender that. It doesn't really grasp that as well as maybe some other medical systems might.
Right. Well, and you spent time abroad.
Yeah.
And in fact, you got to sample, and I'll let you tell the story.
Yes. There were errors made. So I used to do like a trip abroad where we provided, free surgery to, people who had never seen money, didn't really know the concept of money.
And where did you go?
This was in India.
Okay.
Which is a very interesting system in itself, right? Because you have a private hospital a mile away that provides state-of-the-art care.
Yeah.
You have a free hospital a mile away that provides, free medical care.
You're right.
But most of the population can't afford the private hospital with guards and green grass and all this. The free hospital maybe provides a doctor, but not the supplies, and there's some underhand paying that has to happen.
Yeah.
And so most of these people can't access either of those things, right? And so that's kind of what the trips were about. And so like a lot of what we do would be like big hernia repairs, right? Someone's got this massive hernia that pokes out, it like drags over their thighs, stuff like that, and they it's been like that for 15 years. Or maybe they have a hydrocele where their scrotum is literally the size of 2 basketballs.
Wow.
Right, and they've had that for a decade.
Wow.
And it's a simple surgery to repair those things. And you offer that for free. And so we would often do like a 10-day trip. We'd maybe do 200 to 400 operations in that time. Wow. And we would do that with not state-of-the-art equipment, right? Because it's a free thing, right? We're paying for our own tickets over there.
Sure.
Luckily we got lodging from someone locally and stuff like that. We have to go there, buy all of our own drugs, and use the equipment that is provided to us in a facility that was never meant to,
really
have operations going on in it.
Wow.
Just a couple of rooms, right? We vent our anesthesia machines just out the window and stuff like that.
Incredible.
And one of the machines we have there, was called it was an old machine that wasn't allowed to be used in the U.S. after a certain point because it was called the Widowmaker.
Yeah. And they're like, well, this is all we got, Travis.
And that's all I got. Yeah.
This discontinued machine. Okay.
Yeah.
Go on.
And you want to still be able to provide the same. You don't want to do dangerous things, right? Over there, even though you have, if you have minimum equipment, you still want to be able to provide the same margin of safety that you would administer to anyone else.
Right.
So you don't want to provide anything substandard, otherwise you're not doing them a true service.
Right.
So we're very cautious about all that stuff. But nonetheless, we still have some old machines that have problems. And I was, trying to figure out a problem with one of our machines. something wasn't quite operating right on it. Didn't seem to be delivering the anesthetic gases appropriately. It seemed very uncomfortable to patients, and we just couldn't quite figure out what was going on. So we were kind of doing these checks to see what was wrong with the machine. And everything just it seemed to be operating okay. And at some point, we're just troubleshooting this thing over the course of like a day. And I was like, okay, like maybe I'll just put it on my own face. Everything's off, of course, but like just I'll see kind of what happens with these kind of one-way valves. If I'm trying to breathe through it and see what that subjectively feels like to me.
Yeah.
And it turned out like one of them was like very sticky, like it technically opened, but you had to like work really hard to get it to open. And that's easy enough to do with just like a breath out and a breath in. And when I took that breath in, it turned out there was a very high concentration of anesthetic gases like within the system. And so I just, inadvertently sucked in a giant breath of
Do you know
gas.
which gas?
Isoflurane.
And that in that one, what is that one? Is that the memory one? Is that the sedative one? Is that
both? Yeah, general anesthetic. Yeah.
And what did that feel like? Because you've never gone under for a surgery.
No, I've never had surgery. I've never experienced anesthesia.
You've never experienced. So what?
Yeah, I don't know what that's truly like. But I guess all I could say that felt like was a blanking.
A blinking.
Like an emptiness. Like it's much like when. If you stand up too fast and you kind of get lightheaded, and then if that were to progress to nothingness,
wow,
it's kind of like passing out, right? And essentially that's what I would have done had I taken any more in.
Wow.
But yeah, it was just like this great sense of nothing. It wasn't like euphoria, it wasn't fear, or anxiety, or anything like that. It was just nothingness.
Well, listen, Travis,
it was weird.
It's very noble of you to test it on yourself first.
Someone needs to travel to the void,
to tell us what's going on, and then we'll tar and feather them because we don't believe them.
Yeah, sounds great.
Speaking of the void,
yes,
let's talk a little bit about my last section, which I like to do with every guest. And these are questions that I've had my entire life. I don't expect to know the answer, but I would love to see what other people have had to say, because they've gotten to roam around this earth in a much different pattern and line than I have.
Sounds scary. Lay them on me.
Okay, well, no, the first one's kind of easy.
Okay.
What is the medical definition of being alive?
I guess I would say something to the effect of having consciousness.
And what is that?
Maintaining homeostasis.
Okay.
Having your vital bodily functions continued.
At what point do you judge someone conscious?
I guess if they respond to stimuli.
Okay.
Of varying types of stimuli. So you can make someone unconscious with anesthetic gases.
Mm-hmm.
So I think just consciousness alone obviously isn't being alive.
Right.
But not having consciousness, you're be alive, but you're not living life.
Mm-hmm.
So consciousness, I think was some state of wakefulness and ability to interact with your environment. And homeostasis is, can your body maintain its basic cellular functions?
Okay. Well, I mean, I really want to get to the root of what is this spark that animates us? So let's say I decide to move a limb or speak or whatever. Can you tell me what the first domino in that decision is? I mean, obviously we have these nerve cells that travel to the spinal cord, that travel to the brain, from the brain. And right, that's how we've set this electrical impulse.
Yeah.
But how did the first impulse happen?
I honestly don't think I know. It's not my realm, believe it or not. Like, I can make people conscious and unconscious, but like, kind of knowing the specific origin or like what exact neurons are happening and what excites them to have a thought. definitely would be like someone with a PhD could perhaps talk about that. All I know is kind of what you would say, like it starts here and then it moves around in there, or it moves down and causes you to have an action.
Right.
But what causes consciousness?
So you would say that what you see is what you get, right? Your body is you. Nothing more, nothing less, right?
Correct.
In that case, do we have free will?
Free will. I think I would like to say yes, we have free will, because it would be very disappointing to think that we don't have free will.
But hold on. This contradicts the previous understanding that we just came to. Do you see that? Do you see that connection?
Yeah, I see what you're saying. Something in my in the world's history has led me to be to a point where neurons fire, and I'm not necessarily in control of that spark. Like from conception on.
Right.
But I feel like that type of thinking where you don't have free will, I don't know. I feel like that doesn't really get you anywhere.
It doesn't.
In life.
I will agree with that.
It's not helpful.
I will agree that it is not a productive thought.
Yeah, I like the feeling of like, oh yeah, I've got free will because I can do something against my better judgment.
Right.
Like everyone says, don't do this, and my body says, oh my God, don't do that, and I go ahead and do it anyways. Like that feels like free will, and
okay.
That's a nice feeling to have. And gosh, I would hate it if I thought that wasn't my choice in the end.
Well, the free will question always comes down, in my opinion, to what consciousness is. Because, let's say that there's matter, right? Of course, I mean, obviously there's matter.
There is matter.
But let's say that there's only matter, I mean. And you have the Big Bang, and you have this entropic, chaotic expansion, which we call the universe, right? Mm-hmm. So far. Then if that's all there is, then I just, in my body, feel this natural, like a ball falling down a little pathway, bouncing around. My neurons that fire are just an expansion of entropy, going from organized to disorganized.
Yeah.
And as I wake up and go through life, every single moment, every blink, every light, everything said to me interacts with my genetic code, that allows me to interpret these things, how well I can hear it, how well I can see it, how well I can remember it, and it just, there is no other option than where I've come to now, and we're just along for the ride. Yeah.
I think that's totally a valid theory.
It's a valid theory? Okay.
But here's the two thoughts I'm having while you're talking about this. One is that could be maybe free will, lack of free will could be very satisfying to a person, right? You are where you are because that's all you could be.
Right.
You can maybe make your life feel easier. I think we could maybe both conceptualize that, right? Like,
of course. Yeah.
Like I'm happy to where I am because there's no other choice to it. Like, but then it could also be like very detrimental, right? Because you could, do something bad and be like, not my fault. It's the universe's fault. They,
right.
It caused me to do this bad thing, and that could be detrimental.
Right.
So I definitely like the thought of having free will over not, but.
Well, and whether we like it or not, whether we're religious or not, people hold beliefs that are irrational in order to have a pragmatic purpose, to get things done, to get themselves through the day. Like, for example, I believe in myself, which maybe is a little irrational, but it helps me. You know what I mean? Like it helps me. I believe in myself that I can succeed or accomplish a climbing goal or whatever it is, or better myself. And I also believe in this idea of envisioning your future. And if you envision it, then the probability of it happening may increase, though conceptually I've come to a point where now I can see that this may be irrational, that this type of thing, this power that one could possess may not be. I ignore that fact actively because it's not productive. And I got to ask you, do you have beliefs that are untrue yet you hold because they help you?
I like to think no, but I feel like I'm generally a reasonably like a logical person, fairly like evidence-based in the things that I do. And so, if new information comes forth, then I would change my opinion on those things.
Well, evidence-based, I mean, you practice evidence-based medicine. And I must ask, because I used to study, medicines from all over the world, Ayurvedic medicine, which focuses on prana and the chakras, this energy flow through the body. And also I used to study TCM, traditional Chinese medicine, which focuses on different acupuncture points, different meridians, the balance of qi and sexual energy and this energy called Shen, whatever it is. Have you, I'm sure you've come across people, it's Portland, it's like you've come across people that have been treated by or have been recommended certain practices by different schools of thought and different areas. What are your thoughts on I guess non-evidence-based medicine?
So I think non-evidence-based medicines like that have a role. And, if I'm going to be talking about it, like, I don't know, I haven't studied those things. I don't know everything about them. But I feel like they have a role, right? Because if you believe they work, they could potentially work for you, right? If you think acupuncture is going to help your pain and you go get acupuncture, it's a great chance that it actually will. Probably even greater if you go into it already thinking that it will, more so than if I tell you it will and you're kind of skeptical about it.
Right.
So I think that has it has a role in those senses. I think where it doesn't have a role would be in contradicting something that's already evidence-based.
I see.
If someone is on a blood thinner because they have a blood clotting disorder and they clot too easily and they've had a pulmonary emboli before, and you see a Chinese medicine doc or a naturopath who says, oh, you don't need that because I diagnosed you as this, and something that doesn't need that, and they tell you to stop taking that drug.
Right.
Like, that's going to have a real serious consequence.
Right. And you've seen it firsthand.
Yeah. Definitely.
Wow. And I guess, a lot of people from the other side of medicine, they look at Western medicine as perhaps closed-minded, but in the reality is that these other medicines are based on essentially scriptures and manuals that don't change.
Yeah, kind of
right.
Dogma, right?
Dogma, which may have some merit and some wisdom to it, but the key to Western medicine, right, is this evolution, is this idea that, like, okay, a bunch of people have proposed this, a bunch of people have looked at it, and we're coming up with new conclusions and throwing out old things and progressing. Yeah. We assume we know nothing. We don't come from a place that we think we know and then work back, right? Am I getting that right?
Yeah. I mean, I think there's, evidence-based medicine is a relatively new thing, I think. And it used to be
the last 100 years. Right?
Yeah. And it used to be mostly, like, I would say, apprentice-based, right? And anecdote-based.
Right.
Which is not entirely different from dogma or, someone using Shen or whatever to treat someone, right? They've been doing that. They have a series of things that they do that they feel has a good outcome, and that's their anecdote. And I think in regular Western medicine, a lot of people do that too, right? Like, you train under this surgeon, that surgeon trained under that surgeon, that surgeon trained, and they kind of just pass that knowledge directly up to you, and so you just do the thing that they say is best.
Right.
So it's just kind of a passed down knowledge that may or may not be the best thing. And then, eventually you kind of start doing evidence-based things, like, okay, do I that type of tumor, do I need to remove it? No, it's benign. You've been doing this operation for 40 years when really you just let that thing alone. Or that thing you left alone, like you should have been operating on that, like, so I feel like you can come across new knowledge, and then you would, evidence-based days, we would change our practice.
I see. And and throughout your career, even you've changed your practice many times based on new evidence that's come out. I mean, how often does that happen, would you say?
I feel like that it probably used to happen quite a bit, when evidence-based stuff started, taking off, and there was much more like randomized trials to, truly get as close as we can to answering whatever question it is. Yeah. In the last decade or so, though, I would say that like it's really dropped off a lot, in my opinion. There's far more studies that people are doing that have a neutral outcome. Oh, really? The thing we tried to intervene on, thought would be better, was neither better or worse. And so, I feel like there was probably lots and lots of changes, before my time in medicine. And I feel like there's fewer and fewer changes, or the changes that we're looking for are much more minute, right? Or that we find are much minute. Like this drug was better than that drug. If we look at 100,000 people who, got one or the other, right. So how important is that?
Well, and one thing to note also, that's, and you said placebo and before, and in all of these experiments, they account for placebo as well, right? For the placebo effect. And I wanted to talk about that a little bit because, for example, Hippocrates, back in, he was born in 400 BC, died in sometime in 300 BC. He was he's known as the father of Western medicine in Greece. And he was known for being one of the first people to point out that perhaps ailments are not caused by superstition or lack of superstition or something outside of the natural realm. He saw them as just a naturally occurring thing that may have natural remedies. And the thing about that is that, yes, ailments may not be caused by superstition and gods and whatever, but sometimes the belief of superstition or gods can cure you of an ailment, known as the placebo effect, right? And can you tell me, because the problem with that is that some people run away with that.
Totally.
They say your mind will cure you of every disease. You don't need medicine. Yeah. You don't need vaccines. You don't need anything. From your experience, in which cases does the mind play the healing role? And in which cases have you seen it's like, no, you need intervention. And if there hadn't been intervention, the person would have definitely died.
Yeah, I think it's, so there are pieces that have a large psychological component to them. Pain is probably the most easiest and obvious example. You can see the placebo effect very strongly in pain. Times I've noticed this, again, working abroad with people that don't have much education at all. You're like, okay, I'm going to give you this pain medication. It's a shot. Maybe they've heard of a shot before. You drop the medication, you roll up their sleeve, you shoot the medication into their arm, and they just go, oh, thank you. I feel so much better. And you're like, like that, drug just barely left my needle. There's absolutely no way that you were feeling instantaneous effect of this. Okay, what a great placebo that was. Like could have just stuck a needle in and pulled it out, and you would have felt apparently way better. Right. So I think, in that kind of a thing can be very strong and potent. But then I think if there's like a clear biologic basis of your ailment, cancer, heart disease, whatever that may be, I think it's can be a very dangerous thing to think that like a placebo medicine can fix that problem, or that to think that the mind can fix that problem. Right? Because then you're mostly just going to ignore your actual problem. You're not going to seek out known treatments for it. And we definitely see that also, where people have tried to use the mind in other ways, through other forms of medicine to treat whatever throat pain they were having, but it turned out that throat pain was squamous cell carcinoma from years of smoking.
Sure.
And they show up at like end stages when it's already gone to their lymph nodes and the rest of their body and things like that.
Yeah. So it's dangerous.
Yeah, it could be dangerous. It could be helpful in certain, just have to pick your battle and
pick your battle and pick your sources, because when people are going off of personal experience, it's it can only go so far because the explanations are many.
And you probably shouldn't step on each other's toes. If there's someone that has a specialty who studied this thing, and you have this specialty and you've studied this thing, and someone's prescribed, just don't undo someone else's work, essentially, or don't try and overstep your knowledge. And kind of you have to be self-aware, I think, to know when you're going beyond your bounds or not.
All right, man. Enough easy questions.
Okay.
We got up to an easy tangent there, man. What is good and evil, and how do you decide? What is your validation loop? When you perpetrate something in your life and you see its effect, how do you internalize it? How do you change your philosophy of it? And what do you define as good and bad?
Okay, a lot to chew on there. Good and evil. So I think the two things that come to my mind are kind of intent and situation, perhaps. Thinking of good and evil, like, if you kill someone because you're curious of what that experience will be like, and it's for self-satisfaction, that seems pretty evil. If you're in the military and someone's trying to kill you and you kill them instead, like, kind of situationally different and like intent different, and so the end result is the same, but one seems very evil and the other one seems self-preserving. If you kill another conscious animal for fun, sport is fun, like, to me that seems kind of evil also, versus if you are trying to survive and you have to kill something to eat and not starve to death, like, your intent is not malicious. Your intent is your own survival. So I don't know, like, those things, I think intent matters a lot, probably, for what is a evil thing and what is a
necessity.
A necessity. Yeah.
Okay. So you're saying evil could be defined as something that is unnecessary harm, just for the sake of pleasure or something like that.
Yeah. Okay. I think that could be, or without thought of what might happen to someone else or some other thing, right? It kind of lacks empathy.
Okay. And what is a good act?
Well, I guess anything else, whether intentional or unintentional, whether what do I say here?
Take your time.
Okay, so I think a good act, I guess, is anything that ends with a good result for someone else. I think you could probably do it intentionally, trying to have a good result. Just thinking about, like, if you do it unintentionally and someone else ends up benefiting from that, like, is that a good act?
Well, what if, for example, the destruction of something else benefits the whole?
I feel like this is like the trolley dilemma.
Okay. That is a great dilemma. I mean, so let me ask you, if there's a trolley's heading towards 3 trapped people.
Okay.
And you could save those people, but when you pull the lever to change the direction of the trolley, it'll kill 1 person.
Yeah.
I want to know your answer, and I also want to tell you that an AI was asked this question.
Yeah.
And I want to know what you think the AI said.
So I would pull the lever.
You would pull the lever?
I think I would pull the lever, yeah.
Okay.
And I think most people would be my guess. And I feel like AI is kind of like based on collection of collective experiences, input into a computer. So I would imagine that the AI would also pull the lever.
Okay. So you would imagine the AI would pull the lever, and you would pull the lever. And what would be your exact reasoning?
I feel like it'd be, averting harm. There's more harm and more suffering that occurs if 3 people get killed than if 1 person gets killed.
Okay. The AI did not pull the lever.
Ooh, interesting. Why not?
It said that it did not know enough as to how and why the situation was the way it presented.
Oh,
and it felt that it changing the course of an event that was pre-organized may cause more harm.
Okay, so needed more data.
Needed more data. It said without sufficient data, those 3 people could have been
about to die.
About to die,
in the next
or
10 minutes anyways.
Die,
and this was a newborn on the other side with a whole potential ahead of it.
It weighed the amount of unknown too great to justify an action that was not necessary.
Okay. Yeah, interesting.
Well, does a human have a predisposition towards good or evil?
Yeah, I think so. I think probably from an evolutionary standpoint, if you're evil and malicious, you were probably less likely to have survived. More things were probably wanted to kill you, and you're probably less likely to be involved in a tribe or a group of people that could provide for each other and nurture each other.
Right.
So I think from a science standpoint, evolutionary standpoint, I have to imagine that people are intrinsically good. Obviously, there's exceptions, but I feel like
that makes sense. I mean, there's always this quote, this idea that evil eats itself. If you can't work together, you won't succeed. And evil's relative as well. But for example, for my animal rights activist side of me, it's like sometimes evil is perpetrated without knowing. But the reality is that, let's say, if you defined eating meat as evil, you could say that will run its course eventually, that people will stop eventually because it's not evolutionarily sustainable and whatever.
So your animal rights side of you is pretty upset right now.
No, I mean, look, it's always upset. I mean, hey, but it's ultimately, I don't think the universe judges.
Yeah. Well, I think only recently it probably became a necessity. Went from necessity to fun.
Right.
So maybe give it some time.
Give it some time.
Don't give up on us.
I won't. Okay. Last question. We've talked a lot about the human body and its abilities and all that. And all I can say is that a human, healthy, functioning human has a lot of avenues it can choose if it has choice. And for those avenues to be expressed, to be nurtured, to be utilized, takes a lot. And I want to ask you, what does it mean to fulfill the human potential? And how close are you to filling your potential? And how much more do you have to go?
I feel like probably every individual out there is a realized person at that moment in their life, right? Like a small kid has done as much as they can possibly do to with the mind and body that they have. So I think they're actualized in that moment. And then as you progress, like you become, I guess, more actualized in your moment. And I don't think there's any endpoint there. I think if you lived forever, you would probably just continuously become more actualized until you reached some sort of, peak. So yeah, I think none of us are fully actualized. Alex Honnold is not fully actualized. He's
getting close.
Great climber, but he's probably got a bazillion other potentials that he hasn't even tried to tap into yet.
Right. And how about for you? I mean, there is the goal of climbing El Cap and Half Dome, and what other avenues of yourself would you want to explore?
I mean, yeah, that'd be great. I'd love to climb those things. If I never do, I feel like I'm still actualized in where I'm at. You know,
Yeah.
I've done the best I can to get where I'm at, and other goals aside from climbing, I think it would just be to kind of continuously improve at whatever it is I choose to do. You know, so my work in medicine, climbing, building relationships, like just getting better at doing those things. Started playing chess the other day. I'm not good at all. I haven't played it ever. Getting better at that.
Very cool.
Yeah. Small things are good too.